Check out this week's StayCurrent Short. Now, let's jump to the most common polyposis syndrome, Familial Adenomatous Polyposis Syndrome.
So FAP, these are autosomal dominant mutations in the tumor suppressor gene APC. It's present in about 1 to 5 to 1 to 25,000 live births. And 100% will have adenomatous polyps in their colon at some point in time in their life. Nearly 100% will have malignant transformation in their colon by the age of 40.
That's Dr. Joseph Palermo. He's a pediatric gastroenterologist and a member of the multidisciplinary polyposis team at Cincinnati Children's Hospital. The mutation in APC can be germline or somatic, but either way, they lead to alterations in the signaling pathway and overgrowth.
So what do we see? So on a scope in somebody with FAP, you'll see these lawns of polyps, thousands of polyps throughout the colon.
These polyps are removed endoscopically and sent to pathology where they look for a few key findings.
Luckily for us, most kids do not have any evidence of high-grade dysplasia, but it is one of the reasons that we are watching them closely because it can happen.
Those polyps aren't only found in the colon, they can also grow in the fundus of the stomach, and while they're usually benign, it's still important to sample and confirm the diagnosis. Plus, we need to keep an eye out and make sure that they don't cause any problems.
More commonly to cause problems in the stomach is if they develop adenomas, because the adenomas will actually form usually closer down to the antrum, and so they can get large enough to actually be obstructive or get sucked in and out of the pylorus. And then, I don't have pictures of it, but also in the duodenum, they can develop polyps and adenomatous change, both in the duodenum as well as in the pylorus, in the ampulla.
They can even get polyps in the duodenum or the ampulla. Now, outside the GI tract, FAP has typical and testable associations. Patients may have bilateral hypertrophy of the retinal pigment called chirpy. They can have bone osteomas, desmoids, adrenal adenomas, or thyroid nodules.
A small percentage will get thyroid carcinomas, and so we do regular thyroid screenings on all of our patients after teenage years. And then for the other interesting association is with hepatoblastoma. About 1%, or less than 1% of patients with FAP will have hepatoblastoma, but hepatoblastoma patients, there's a high rate of patients who have APC mutations. So we are very careful to screen our patients under 5 years of age.
When deciding which patients need screening, be on the lookout for families with a known APC mutation or a first-degree relative with FAP, but this is medicine, so there are always cases that don't quite follow the rule.
The 20 to 30% of spontaneous mutations in patients with FAP, so there is no family history. And again, 10% of patients who truly have FAP with lots of adenomas do not have an identifiable mutation. So you don't have to have a mutation to have FAP, and we still screen those patients without a known mutation in the same way.
Let's break down the screening recommendations. At 10 years old, the screening starts with the colonoscopy every 1 to 2 years. For kids under 5 years old, the screening is pretty rigorous. Check out the table with screening guidelines below. At Cincinnati Children's Hospital, we also use a screening upper endoscopy while patients are under general anesthesia.
We generally here will also do an upper endoscopy, because there can be findings on the upper endoscopy of things besides polyposis, and so if a kid has belly pain, it'd be good to know if they have bad gastritis or H. pylori or something else, and so we like to have that as a baseline, and if they're going to be in anesthesia, we would rather just get that scope done at the same time. Again, we started around 10 to 12 years of age, but it can certainly be sooner if they have any symptoms, pain, diarrhea, bleeding. If there is a family history of colon cancer at a young age, there are reports of colon cancers in these patients as early as their late teens, and so if a family member at 18 had colon cancer, we might start their screening at 8 or 7.
If you identify a polyp on screening, then yearly endoscopy is needed.
If you don't see a polyp with their first scope, you could probably space that out safely to 2 or 3 years.
Surgical resection is needed once a cancerous lesion is noted or if the patient's having significant symptoms. But there are some relative indications for a colectomy as well.
Relative indications are when they start to have multiple large polyps, greater than 6 millimeters, again, because of the risk for complications like obstruction. If there's a significant increase in adenomas, the literature says less than 50, but we will often still monitor them if they stay small and don't start looking abnormal, and wait till they get to larger numbers, only because of, as I said before, trying to personalize or individualize the timing of when they would have their colectomy. Obviously, if there's high-grade dysplasia, then we go pretty quickly to colectomy. And then, as you saw, when they have those lawns of polyps, and it's really impossible to do adequate surveillance, that certainly is the time to do it. And we generally try and do it, I'd say on here, say greater than 20 years, but we actually try and do it less than 20 years. We try and do it before they head off to college and before they leave our purview, because once they head out into the real world, we often lose contact.
And obviously, if they have cancer or high-grade dysplasia, large polyps, or too many polyps to reasonably surveil, then either a total colectomy or a total proctocolectomy is the operation of choice based on the rectal polyp burden. But following surgery, surveillance isn't over.
Both with total colectomy and ileorectal anastomosis, as well as with total proctocolectomy and anal anastomosis, they still require annual surveillance of the cuff or the pouch. And the cuff, obviously, certainly because it's still colonic mucosa, but even in the pouch, which is ileal, they still can develop adenomas and cancer. So they continue with their yearly surveillance indefinitely.
The literature is still unable to identify effective non-surgical therapies, but options such as chemoprevention, aspirin, and NSAIDs, well, they've all been investigated, but so far, nothing's decreased the progression of disease or improved long-term outcomes. But the good news is aspirin and NSAIDs, they can reduce the polyp burden.
There has been one good prospective randomized controlled study in kids. This was the CHIP study, which looked at Celebrex in patients 12 to 17-year-old. It was a double-blind randomized placebo-controlled study with 100 patients in both arms over 5 years, so pretty decent follow-up time. And what you can see here is the placebo in circles and the Celebrex in squares, is that really at the time of 5 years, there's really not a significant difference between the two in what they're looking at, which is the event, which is for them appearance of greater than 20 polyps that are at least 2 millimeters in size.
What they found in that short term is that Celebrex seems to decrease the total number of polyps, but after about 5 years of therapy, there's really no significant difference between Celebrex and placebo. If you want to read more, we have this study and the images linked below.
Smaller studies looking at both other NSAIDs as well as mTOR inhibitors, EGFR inhibitors, immune modulation, some of them alone and some of them in combination. But unfortunately, they all have similar outcomes, meaning that they may slow or decrease the number of polyps, but do not actually prevent regression.
FAP with an APC mutation is the most common hereditary polyposis syndrome, and there are special subtypes to be aware of.
There are a couple other subtypes of FAP. So Gardner syndrome, named after Dr. Gardner, who identified this back in 1950s, is a variant of FAP, and it basically you have the same adenomatous polyps in the colon, but they are more prone to develop desmoid tumors, as well as osteomas, epidermoid cysts, and the periampullary tumors, the duodenum.
Charcot syndrome has the commonly tested CNS tumors and gangliomas, while attenuated FAP has a slightly different disease trajectory. They have fewer polyps at a later onset, so screening starts around 30 years old.
The lifetime risk of cancer is lower than in classic FAP, but it's still, as you can see, very high.
Check out the full episode on YouTube, the StayCurrent app, or SoundCloud. Find the links below.